Welcome, listeners, to Diversion Insights. My guest today is Michael Staples. Mike is a healthcare regulatory compliance expert. His journey to present day work is a very interesting one. So I want to start there. Mike, give us a bit of your story of how you went from detective to compliance expert. And I should say, welcome to the podcast.
Oh, thank you, Terry. Thanks for having me. Well, my journey was an interesting one. I never thought I would get to where I'm at now. However, I started my career as a police detective and spent about 10 years doing that with a focus on drug crimes. And I started getting interested in professional crimes as far as like pill mills and doctors illegally prescribing cases towards the end of my career. And a position came open with the state medical board as an investigator. So I applied and took that position. And then I was with the state medical board approximately 10 years. And then I left the state after investigating, licensees, both doing criminal investigations and regulatory actions. Became director of compliance for a large pain clinic in the Cincinnati, Ohio area and started teaching CME, which I did a little bit when I worked at the state. I taught CME on aberrant behaviors and documentation. So I kind of transitioned when I left the state and doing more private CME. And actually, before COVID, we had a very robust controlled substance prescribing course that I created along with some attorneys and medical professionals. But after COVID, that kind of ended all the in-person CME
Sure.
events there for a while. And I started doing more and more with consulting, helping physicians get in compliance, or if a physician actually got into trouble for, allegedly improperly prescribing controlled substances or for some alleged fraud, I would help their attorneys and help the physician not only get in compliance, but also build up a good solid defense, you know, for the physician's case. And since then, I've been sworn into federal court as a healthcare compliance expert, and have done hundreds of consultations, and also been director of compliance for a few national companies, including a national telehealth company, um, paying clinics in other states as well. Sometimes they'll contract with me to be their compliance officer because it gives more credence having a third party compliance officer than someone that's, you know, could be perceived as biased working inside the office as the compliance officer.
Right. Yeah, absolutely. Yeah, that makes sense. Okay, so you've learned the clinical aspect of healthcare along the way, I would assume.
Absolutely. Working in two large pain clinics for probably a total of 5 years has gave me valuable insight into the medical clinical side of not only prescribing but just medical operations in general, which has helped me become way more versed in not only compliance but also helping physicians build defenses and also common sense, because a lot of experts for the government and experts for other sides, they don't look at the common sense factor when it comes to patient care and providers being compliant with the rules and laws. There's compliance, and then there's common sense, and there has to be a correlation.
Right. Yeah. So let's talk about that. I'll be curious to hear if you, well, let's just do that now. When it comes to court cases and legal cases, I don't know if common sense always wins out. Do you see that play itself out very well
It it
when you
it it does when you have the right legal counsel and the right jury. Common sense doesn't play out if the case is presented directly to a judge, because the judge is just going to interpret the letter of the law
right?
and not take in consideration, common sense. But when you are playing to a jury, the juries, you know, they're humans, they're everyday citizens, and they're going to use common sense in their reasoning.
Okay.
And so therefore common sense, in a lot of these cases can be a strong defense. When you have a physician that has no prior criminal record, has never been in trouble before in their life, and they're accusing him of being some mass drug trafficker because he has a certain number of patients on controlled substances that have documented medical reasons, common sense would say, is this person really a drug trafficker? Because,
Right.
they have no criminal record. They're not making any money besides what little copays they're getting or what little reimbursement they're getting
Mhm.
from Medicare, Medicaid. So common sense, to me would play out that no, this person might be a little naive, as a prescriber, but it's definitely doesn't have a criminal bone in their body.
Right. Okay. Yeah, we're going to talk about that too, naive versus criminal.
Sure.
But I want to start with corresponding liability that applies to pharmacists and physicians as well. So let's talk about that first for our listeners that maybe are not familiar with that term. What is that?
Well, physicians and pharmacists have a corresponding 50% liability, when they write a prescription, especially a controlled substance prescription. So the physician writes the prescription and then takes it, the patient takes it to a pharmacy. Well, the filling pharmacist has a corresponding liability to that prescription. And a lot of people don't really understand it, including a lot of people at the government level. A pharmacist is really supposed to just verify that the prescription's legit. Okay. But the government has unfairly targeted pharmacists and got it to a point where they make the pharmacists feel like they have to do the medical decision making and medical necessity, which, they're not technically trained to do. They're trained, is this drug a good fit, for this condition? So, it's really become, you know a mess out there with the government targeting physicians and pharmacists that are doing nothing more than their job. They want doctors to be detectives and pharmacists to be full-time detectives when they already have incredibly busy schedules, both
Mhm.
professionals. So you have to be able to protect yourself and protect your license while trying to be the best detective you can as a
Mhm.
licensed professional with no experience in investigating these things,
Right.
which is completely, unfair. Um, so that liability, if you have a physician that is a bad player, let's just pretend that he is a bad player. He is just selling prescriptions for cash. People walk into their office, a traditional pill mill type structure. People walk in his office. They hand him $500 in cash, or they don't even see him. They might hand his front desk staff $500 in cash, and he writes them a prescription, more than likely for a drug combination. An opiate, a benzo, and a muscle relaxer, preferably a soma.
Yeah.
Um, Houston cocktail, Las Vegas cocktail, Portsmouth cocktail. It has many names. So he hands them these prescriptions for a cocktail. They take it to the local CVS pharmacy. The pharmacist looks at it and says, "Oh, well, this is a cocktail." Okay. If that pharmacist just fills those three prescriptions without doing any due diligence or anything regarding his 50%, you know, his liability 50%, corresponding responsibility, that pharmacist could be charged, with a crime, because they'll basically say, you knew this was a drug cocktail, you didn't look into it, you didn't verify legitimacy of this. And so what licensees need to do, both doctors and pharmacists, is making sure that they document these things. So, if you're a physician, now not Mr. Bad Physician that we just talked about, but a normal good physician, you want to make sure in the medical records that you're documenting, the medical necessity of the drug, the lack of any adverse or side effects, because you know, I'm going to be brutally honest with you. There are patients out there that are on that cocktail and have been on it for 20 years with no adverse effects,
Hmm.
um, hold down great jobs and provide for their families. And without that cocktail, they would not be able to function. They've tried it.
Wow.
I've seen the records. I've been in thousands of offices. I've
Mhm.
reviewed tens of thousands of medical records, and I've talked to some of these patients. And these patients, they have no criminal history, no compliance issues. All good urines, all good, PMP checks. But there are patients that actually need this type of combination. Not saying I endorse it in any way.
But it's
However,
not, yeah, it's not an automatic red flag, don't fill.
correct. It needs to be looked into, and that's where the corresponding, responsibility, lies, is doing your due diligence. Whether you're a prescriber or a pharmacist. And a lot of pharmacists make a mistake because they call the physician and they start questioning their medical decision making instead of just verifying the reasons why the prescription was issued. Because most laws regarding corresponding responsibility, state that the pharmacist has to verify the prescription, not question the doctor's.
Challenge.
Yeah.
Yeah.
Um,
Okay.
and that's where a lot of problems lie. But the government sometimes will use this in court improperly, and they will fault a pharmacist for not doing more of the medical decision making challenges, which is not their job. They're already busy enough. Really, what they should be doing is, documenting and verifying that, number one, the prescription is legitimate. It was issued by the provider. It's not a counterfeit prescription, and a lot of times they can do that by contacting the physician's office and asking to speak to the physician, or if they trust the staff, getting that staff and having, the original faxed over if it's a paper script, or just verifying that, this patient is seen, and the prescription was issued by the uh, prescribing physician. The second thing, they should verify is the PMP report. So the pharmacist should run a PMP report, on the patient to make sure, he's, number one, he's not getting it from somewhere else, that he's been getting this same dosage for, a long time, etc. And sometimes you even go a little step further. And when I do consults for pharmacies, sometimes that are being scrutinized, by the government or the state, sometimes I advise them how to check criminal records, of patients. And I don't want pharmacists checking criminal records on every single patient that walks in the door. But
Right.
there are free resources out there that I help pharmacists uh, know about and also check. So if they have an issue, especially, let's take one of the worst drugs that the government hates, okay, and it's always scrutinized, oxy 30s,
Okay.
30 milligram oxycodone. It has a very high resale value on the street, sometimes $1 up to $2 a milligram, street value, and it's, highly sought after. But again, there's some people that's been on that drug for 20, 30 years without any adverse side effects, no sedation, no, nothing that would cause them any problems. They're holding down jobs. They've had no criminal record, and they're compliant in every possible way. So we don't want to stop that person from getting a legitimate script just for the sake of it being a Oxy 30. And that's what I see a lot with these investigations and these state actions. Just the fact that they're on an Oxy 30 is crazy to the government. However, there are plenty of people that need this drug, and I've interviewed them myself. I've looked at their medical records myself and scrutinized these people, both as a former investigator and as a private consultant. And it's sad because I've actually met a guy that had a 10,000 morphine equivalent dose. That he was on that many oxycontins. His morphine equivalent dose was 10,000 a day.
Holy cow.
Yeah, and that was as an investigator. And I'll be honest with you, is like we went out to his house because this physician actually used to speak for Purdue Pharma, and he titrated this guy up to these high levels. And we went out to his house on a surprise visit, and counted his medication and watched him dose. And all of his medication was accounted for, and he dosed. I'm talking about handfuls, of medication. It was the
Gosh.
craziest thing I ever seen. And, we sat there and talked to him for a good solid hour after that. There was no change in his demeanor, no any, effects other than he says he doesn't have the pain. He can cope with the pain. He says it's not 100% gone, but he doesn't have the pain. But yeah, 10,000 morphine equivalent dose. One of the patients I saw, and it's crazy, but it got to the point that no one would prescribe to him because of all the scrutiny. So I don't know whatever happened with this guy because I left the state, but I'm sure it didn't end well for him because you can't go from those high levels down to a low level unless you're completely detoxed. And then it still might not even work, and you could also kill somebody from dropping those levels like that. From the stress on their body. From the sudden pain and everything. It's scary, but pharmacists should make sure they're covering their corresponding responsibility, and you've got to make sure you document. If you don't document, it didn't happen, just like in medical records. So when you're covering yourself on corresponding responsibility, you want to make sure you keep the documentation. Don't just do it and issue the prescription, especially if it's a first-time patient coming to your clinic. I use a checklist sheet sometimes that I give to my pharmacist, and it basically addresses all the red flags, and it makes sure that they verify all the things that the government would look at to make sure this is a legitimate medical prescription, including making sure that the patient has the right ICD-10 codes for the pain. The patient has no signs of aberrant behavior. They're not coming into the pharmacist, appearing sedated or intoxicated, things like that. That it's documented that the prescription monitoring report was looked at. It's documented that the provider's office was contacted and they verified the prescription. Just basically covering yourself, and that way, if a government entity would ever come in questioning your filling of that prescription, you can pull out your basically compliance folder and show every time you've done this for every patient. And if they have a particular patient, you can go right to that sheet and say, here's where I did my due diligence and did my corresponding responsibility by verifying that this prescription was a technically not a medically necessary, but a verified prescription.
Valid. Yeah.
Valid prescription, yes.
So what would you say to the pharmacist that does all of that, but still either they've seen prescriptions from a particular physician, the physician's office will answer the phone and will say, yes, I wrote that prescription. But either this local pharmacy is seeing repeated patients. There's just something about it that they're like, everything I can check on this checklist and file this away, and I did my due diligence, but I really think something is going on here.
Yeah. And sometimes those thoughts are correct and sometimes they're wrong. But do we really want to punish the patient based on, a gut instinct or, a thought, a consideration? So you got to do your due diligence. However, my advice at that point would be look into the physician, check the board website, see if there's any current board actions against the physician for inappropriate prescribing or any issues related to his prescribing. And then you can kind of leverage that to possibly, not fill the prescription or refuse to fill the prescription. Because if you have a lot of documented evidence that a physician is not doing what they're supposed to be doing, then by all means, you should get rid, not fill that prescription.
Right.
But
you could also add it to your checklist to say, I went the extra mile and there don't seem to be anything against this physician's license. So
correct. And you shouldn't be denying patients on a gut instinct. I mean, it's different if they come in with track marks on their arm and they're slurring their words and where's my oxycodone? That's a lot different. But
what about the patient that is the opposite, where they come in and they're not impaired or slurring, or they're very clean and they look professional and they're not taking it for themselves, they're selling it?
Yeah, that does happen. But again, the only thing you can do is what's available to you. I mean, you can't babysit these patients. You can't conduct surveillance on these patients. And the government sometimes they do look at it like, they expect you to be in their house 24 hours a day watching what they do.
Mhm.
Uh, you know, you can't turn a blind eye, but at the same time, when you've done all your due diligence,
Okay.
what else can you do? Because yeah, okay, well, I have a hunch that this patient is selling their drugs. Well, what if your hunch is wrong?
Right.
And you start denying these patients their prescriptions. They have an insurance that's locked into, say, CVS pharmacy, just as an example. And a lot of insurances now are locked into certain pharmacies. So they can't get their prescription. What are they going to do for their pain? Unfortunately, I've seen it 100 times. They go to the street and try to buy the
Mhm.
medications, which
Mhm.
sometimes are counterfeit and contain, illicit fentanyl, and they overdose and they die. You
Yeah.
know, uh, and that's not what we want. We want
Right.
people to do their due diligence, as prescribers and as pharmacists, but at the same time, they cannot be detectives 24/7.
Right. Yeah. And I guess like I know of a situation, this was years ago, and this was a patient that was coming in for the fentanyl lollipops.
Mhm.
And the buyer was noticing that each month that the patient came in, they just came in a day or two early, right? So now you fast forward 6 months and they're very early, but it was just a day or two early.
Right.
And there were other things I believe that they were getting in addition, but this person got more and more dressing better, looked more professional as
Sure.
the months went on that they came in. And it's like, wait a minute here. So they reached out to the physician
Mhm.
to express the concern. And I don't believe that person was being drug tested for anything. So, in collaboration with the pharmacy, then the physician's office instituted the drug testing and found that everything was clean. This patient wasn't taking those
Right.
meds.
And that's why there should be good solid communication between the physician and the pharmacist. I will say that if you as a pharmacist contact the provider's office and the provider won't get on the phone, I mean, most states actually have rules and laws that state they have to answer the call.
Okay.
That would be a red flag to me if I was a pharmacist. you know Uh, Now, there are some physicians that have had bad experience with pharmacists questioning their medical decision making, so they're hesitant to get on the phone. But if I was a pharmacist, I mean, obviously, I would be very professional and courteous, and I tell the physicians to be the same way.
Right.
It doesn't ever pay to be rude to anybody. It's just going to, no matter what side you're on, it's just going to initiate a
Right.
complaint to a government
Yeah.
office.
Right.
So always be professional, but that's why there has to be good communication. And that example you just gave is a prime example of pharmacists and physicians doing what they're supposed to be doing. Because why this guy or girl wasn't being drug tested is beyond me. Because that type of dose, most state rules at least. Um, well, actually, some states actually mandate urine drug screening. Not all, but from a standard of care, they should have been drug testing that patient when they
Right.
started him, and also for monitoring as well. Um, but on playing devil's advocate, what if that patient started getting those fentanyl lollipops, and because he was able to control his pain, finally was able to go get a job and was able to buy nice things? You see,
True.
I mean,
That's true. Yeah.
there's a flip side to these
Yeah.
things, and that's why red flags were you know, never meant to be evidence, in a court of law, because red flags are just something that's supposed to bring your attention to something
Right.
and have you look into it.
That's true.
Uh, you know, it's I recently testified at a federal court case where you know, the prosecutor was alleging the doctor was a drug trafficker because he had patients coming from Florida to Kentucky. Okay. But when I testified, they asked me, Mr. Staples, don't you think that this person is a drug trafficker if he's got patients coming from Florida to Kentucky? And I advised him, no, sir, I don't, which really confused him. But um, I went on to explain that, Kentucky, like Ohio, Indiana, are snowbird states. And a lot of these patients, they go south for the winter. And because of these rules and regulations and government scrutiny, a lot of these providers in Florida will not temporarily take on their pain medication. So these patients that have homes in Florida during the wintertime, a lot of times they have to travel back, to
Mhm.
Ohio or to Kentucky or to Indiana to get their controlled substance prescription. And that's something that should be looked into. So if there is a red flag, you do have a patient coming from Florida, and they go to there for to be a snowbird. That's one thing, you know.
Right.
But if they're coming up every single month, they live in Florida permanently and coming to Kentucky.
Right.
No, you should not be filling because
Okay.
obviously something's going on because they're driving or flying past about 500 pain doctors to get back to Kentucky.
Right,
You know.
right. Which again, though, points to physicians aren't detectives either, right? You can only believe what you're told. So aside from the drug testing, legitimate, tests that you order, MRIs, what have you, those types of things, what other things can physicians do? Because I mean, they could be duped as well. I mean, you only know what I'm going to tell you.
Again, making sure that they document, I always tell physicians, and some EMRs, they already have this, but, basically create a compliance section in the note or, where you're checking, the urines, the PMP reports. I always tell all my physicians that I consult for to check the PMP every single visit.
Mhm.
Don't wait until, some states, it's every 90 days, or if you change the
Right.
prescription, you should be checking that prescription or that patient every single visit because number one, the PMP is free. It's not costing you a thing to check it. And it literally takes 2 seconds. In most of the states, you can have a delegate run the report
Mhm.
for you. It's going to take you 2 seconds to look at it. Okay. And you're going to document that every single visit, check the PMP and it was compliant, or non-compliant. And if it's not compliant, you better be able to justify that or explain that or, what you did, in the course. Urine drug tests, they should be random. A lot of these
Mhm.
practices I go into, the doctor gives them once a year or once every 3 months like clockwork. you know if they are a bad patient, and they know that you're going to drug test them every 3 months, they're going to party or sell their drugs for the entire 3 months, and then they'll keep a few back to take right before their 3 month visit.
Mhm.
And I've seen it from working in pain clinics.
Mhm.
I even seen where, EMRs are great and, giving patients access to patient portals are fantastic as well. However, a lot of physicians would write in the notes, you're in drug screen at the next visit. Well, the patient can log into the portal and see right there that they're going to have a urine
Mhm.
drug screen or a pill count next visit. So you also got to kind of be careful, if you got somebody that you're want to scrutinize, that you don't give
Sure.
your give yourself away.
Right, right.
um
Interesting.
but but just like the medical necessity and the medical decision making, everything must be documented. So all your aberrancy checks, and if you got a real bad patient that you think, like, I always tell physicians, if they do have that feeling that they're bad, they watch them, you know jump out of the car when they come to the office like they have no pain, and then when they get to the office they're walking like they're crippled and can't walk at all. Things like that are, obvious red flags that need to be, checked further. And, you must be random in these checks and you must document everything. And there's other things that you can do, just like I instruct the pharmacists about checking criminal records. I also instruct the physicians, when they have cases where they can't quite put their finger on it, to check criminal records.
Mhm.
If you see a criminal record when they was in college for smoking marijuana or
Yeah.
intoxication, no, you don't count that. I'm talking.
Circumstances and common sense come in
Yeah,
again. Yeah.
exactly. Yeah, you want
Yeah.
to look for recent episodes of drug trafficking, something that
Mhm.
they're doing, or felony drug abuse. Not something where they get stopped for marijuana,
Yeah.
or something from their college ages. just like, we talk, just common sense. And you want to make
Yeah.
sure you document all that. And it's appropriate, it's, pertinent that you're seeing these patients. If you have a patient on a controlled substance, especially, a higher dose opiate, you know, you should be seeing these patients every month, just to make sure, number one, there's no adverse effects, there's no side effects, but also to monitor their compliance. You can't do that when you're seeing someone every 3 months or every 6 months. You're not going to be able to adequately monitor their compliance. And they're going to use that against you when you do get into court. Unfortunately, they're going to be, say, well, hasn't seen this patient in 3 months. They don't know what he's doing, or hasn't seen this patient in 6 months. The physician don't care what they're doing. And there's no way, like I said, you're back to that point where the patient knows that you're going to urine test them because they're only seen 4 times a year. So, they know they're not going to be called in for a random urine.
Yeah.
And there's other things you can do. Pill counts are very inconvenient for both the physician and the patients, but there are occasions that I do believe they're necessary. And with today's technology, I actually developed this during COVID, doing pill counts over FaceTime.
Sure. Okay.
So, I would contact the patient, say, I need to do a pill count. They would give me 1,000 excuses why they couldn't come in. I would say, "Oh, you've got an Apple phone. Let me FaceTime you," and then you just lay out the pills on the table, show me the prescription label, and then a lot of times you would just take a screenshot. Once they've laid them out on the table, and obviously when you're doing a pill count, you want to make sure the identifiers on the pills match the identifiers on the bottle. But I've had many a patient or physicians now do those surprise pill counts, via FaceTime or any video link. Because then you can see without too much inconvenience, whether the
Right.
patient is compliant or not. Um, but pill counts, like I said, they are very inconvenient. People do work, people do go on vacations. Like before COVID, when I was director of compliance, I called a patient for a pill count. He said, "Hey, I'm in the middle of Lake Cumberland and my friend's boat fishing. Like, there's no way I can get there by the close of the day." Because I would always call them first thing in the morning, have them come in by the end of the business day. So, I advised him, "Hey, you got a smartphone?" He's, "Yes." I said, "Do me a favor, take a selfie holding 3 fingers up on the lake, show and send that to me." So within 2 seconds, boom, I got a text. It was him, in the middle of the lake, holding 3 fingers up. I said, "Okay, uh, next time we have an issue, we'll call you for a pill count, but this time, we're going to give you the benefit of the doubt."
Right.
Because
Okay.
again, common sense. I mean,
Right.
he was honest about where he was, so we let it go. But then I had another patient that I called for a pill count. And he said, "Well, I'm in Nashville at my aunt's house." And I said, "Okay, well, what's the address?" And he said, "Well, I don't know. It's my aunt's house." And I said, "Well, walk out the front door and look at the numbers on the mailbox or on the house,
Yeah.
and look at the street sign and tell me the address." And 1,000 excuses why he couldn't do that. I said, "Okay, give me a landline, at her house. Give me your." "Well, I don't know her phone number." And it
Yeah.
just went round and round and round until I finally, I had to use detective skills, but I finally got him to admit that he was not in Nashville. He was out of his prescriptions. He had obviously either overused or sold, so we just went ahead and
Right.
discharged him from the practice. But again, common sense, in those things, and you know, documentation of um, not only the urine drug screens and whether they're compliant or not, and the PMP and possibly pill counts, but also make sure you're documenting, about the effects of the medication, that there are no sedation or side effects, because that's something that'll come in play if you ever do get in trouble. Is they'll because they're going to accuse you of overprescribing and the patient overusing. Well, if you are really overprescribing, the patient's overusing, they should have adverse health effects.
Yeah.
So you want to make sure all that's documented, in the chart as well. Also, document the uh, analgesia of the drug, from whether it's they're getting at least 30% relief from the medication, because
Mm.
if they're coming in every single visit, their pain's 10 out of 10. Well, what's your pain on the medication? 10 out of 10. Then why are we giving them medication to begin with?
Right.
Because there is no improvement in their lives. There has to be a reason a patient gets pain medication, so there should be um, you know s- some proof of the efficacy of the drug, showing that the patient was able to achieve good analgesia.
Yeah. Okay. Well, that takes, yeah, it's a lot
Oh,
of
it's and
for
that,
the
that's
physicians to,
that's just the tip of the iceberg. The
yeah,
things that they look at, and the things that if I come out and do a consult for a physician or a pharmacist, the things that I point out to them and make them aware of, and how to better their documentation and better their checks, so they can
right.
not have to stress over that.
Yeah, or hire a real detective.
Yeah.
Um,
Well, no, you can't do that. We got there's a case pending in
oh,
Pennsylvania, where a group of pain physicians hired uh, ex narcotics detectives to screen their patients,
mhm.
prior to them seeing them.
Uh-huh.
Great idea, and actually the state loved it and had them testify in front of the state legislature and everything. However, uh, when it comes down to it, they're trying to say that the ex-detectives, were making medical decisions on the patients, which is not true. They're just checking to make sure they wasn't drug traffickers, or had any
Right.
issues. So you can't win sometimes, regardless of what you do.
Hmm.
But you can, just do your best to show that you're not a criminal, you have no intent, you're just trying to help your patients, whether you're a pharmacist or a physician.
Right. And really keep your records. Do you have a feel for, we hear it in the news, right? When one of these things goes down and oh, pill mill and what have you. What percentage of the time do you see a case where they may not have followed every single regulation, or they may have not kept as good of records, so they
Mhm.
could certainly have done better, or there may have been some fault in their record keeping, but they're not criminals? What percentage of the time do you see that? Do you have a feel?
The cases that I've been involved with, as a healthcare compliance consultant, 100%.
Oh.
It's really scary. We had a physician in Kentucky, internal medicine physician, and it was during COVID, and it was one of those situations where the documentation could have been better, but an undercover agent was sent in, and the agent was complaining of pain every single time. And back when we did doctor investigations, we would tell the undercover not to complain of pain, because doctors have a duty to treat medical conditions. So you don't want to get them in a situation where they're kind of like professionally bound to do something for you.
Mm.
We would typically get the doctor in the room alone, and then say, "Look, doc, this medication just makes me feel good, and such and such patient friend of mine told me that you would be willing to give that to me, or whatever," because that's the kind of people that we want to take off the streets, the ones that are actually giving the medication for a non-medical purpose. So in that
And
situation,
they'll just do it. Like they don't even
and they
expect their
just do it, and
patients
they
to
did do it.
pretend.
They
Oh,
did
that's
do it. Some
funny.
of those pill mills in Portsmouth, Ohio,
Okay.
back when I was, with the state, you would basically walk in and order from a menu. So they would have all the drugs and the costs, and you never saw a physician. The front desk was filling out, pre-signed prescriptions, filling out the
Okay.
body, giving them to you. You was giving cash. Most of them, if you're lucky, they had a bathroom scale. They had no medical equipment. I've not seen a true pill mill in years.
Hmm.
Because the government, most state governments have enacted, took away, like, the corporate practice of medicine, and enacted regulations on who can have a pain clinic, and there's so much inspections now relating to pain
Okay.
clinics and pain management, that it really cut down on the true pill mills. Now,
Okay.
are there still some bad actors out there? Yes. There's still prescribers that may have addiction issues themselves, and
Mhm.
so they kind of do a little bad thing so they can get the drugs that they need for their addiction, or they use their position of power to obtain sexual favors from patients. In exchange, they give them, controlled substances. And those providers or prescribers are the ones we should be targeting, and they should be
Right.
taken out. But the ones like the doctor in Kentucky, he was just, not really good at documenting, and especially it was during all the hectic, COVID time. And so he had a lot of patients coming in, and he was doing a little hybrid model where he would see uh, patients, they'd come in, maybe see the MA, do some checks or whatever, and then he would call them on the phone. So they would come to the office, but he would segregate them, and usually
Okay.
have them wait in the car, and then he would do the call on the phone. And if he needed to do an exam in some extenuating situation, he wouldn't tell him to come back in the office. But he would make sure that everybody was separated and everything. And again, he was just billing insurance. He wasn't making any extra money. And they sent an undercover in who complained of pain every single time. Made 1,000 excuses, and even went and got X-rays done and urine drug screens and things like that. And this was like probably a 60-year-old guy. It wasn't some young fit person that came in like we used to use when we did undercover investigations. This was somebody that you could look at, overweight, and say, wow, I bet he does have pain.
Yeah. Arthritis when you do your
Absolutely.
scans.
And this poor doctor actually saw him like 3 or 4 visits before he prescribed him anything. And when he did prescribe him something, he prescribed him starting out tramadol.
Oh, okay. Yeah. Yeah.
And then the guy kept calling back, harassing the doctor, saying, "Doc, this isn't working. I can't work. I can't. I'm having all this extra pain. I need something stronger." And doc, say like, "Listen, you need more time to let the tramadol work. If it doesn't, if you keep taking it and it doesn't work, then we can discuss something, more." So after about a month or so, after constant hounding, I mean, this undercover's calling, constantly hounding this physician. Um, the physician gets on the phone with him, and again, he says this tramadol's not working. So he says, how about you trying some Tylenol threes? And the patient's like, "Well, I was really thinking about Norco because my friend is on Norco and he said it really helps him, you know." And doc's like, "Well, I can do 5 milligram. It's not much different than a Tylenol 3." And he's giving him like 15 pills. Like, I mean, it's just crazy. And you know, after about 2 weeks, the undercover calls back in wanting to add Gabbies. He calls them Gabbies.
Babbies.
Yeah, and it's like street name for gabapentin. Well, this doctor had no idea what a Gabby was, and even the office staff that answered says, "I don't know what you're talking about, Gabbies." And he said, "Gabapentin." Oh, okay. And the doctor didn't think anything of it. People called drugs different names, and so he said, "Well, I want to add Gabbies," and the doctor said, "Look, you haven't done or shown me any reason to add gabapentin because you haven't shown any evidence of radicular pain or any complaints of radicular pain." And this guy argued with him and said, "Doc, I told you from day one you wasn't, basically you wasn't listening. My pain was traveling from my neck to my shoulder to my back. I told you that." And he was very adamant on the phone that he told the doctor this. So the doctor said, "Well, let's get some more x-rays and let's reevaluate it." And the guy kept pushing and pushing, that he's having all this pain and all this pain. So the doc gave him the lowest dose of gabapentin, again, 2 weeks worth. Okay. And said, "I'll give you 2 weeks, go get the tests, and then we'll reevaluate it, in 2 weeks." We're talking about gabapentin, tramadol, and later a hydrocodone 5. um, and so after 2 weeks, when the guy called in for his visit, it was just during COVID times, and because of the documentation, he just automatically refilled the prescriptions. He missed that. So they charged him with drug trafficking in federal court.
Wow.
Yep. And that was actually the case that I testified on about the Snowbird.
Wow.
And now he was exonerated, but it cost him a lot of money.
I was going to say reputation, financial.
Reputation and everything. It was just absolutely horrible what happened to them. But that was a case where, were the notes fantastic? No. But was he doing anything criminal? Hell no.
And he even tried. to
Yeah,
not do those. Yeah.
absolutely. I mean,
Right.
I've never seen where, he kind of followed the escalation too. Okay, tramadol's
Mhm.
not working, like,
Mhm.
because at first he told him to take ibuprofen, something, over the counter,
Sure.
which the undercover even complained that he was taking so much his stomach was killing him. Which would again give more credence to the fact that okay, he can't take that anymore because it's
Mhm.
causing adverse effects. So let's
Right.
give him a tramadol. But that was the kind of case the government brought, and luckily the jury, found him not guilty. Yeah, great guy, great physician, one of the best like he had a sixth sense for diagnosing people. Like he could look at somebody and tell what was wrong. I mean, he found like uh, there was patients that he had found that were uh, going to have strokes or massive coronaries that just on just his sixth sense he sent them to the hospital and saved their life. There was countless patients like that, or he
Wow.
uncovered an autoimmune disease that no one was aware of. He just had that sixth sense. He was so dedicated to his field. Some people just develop that what I call a
Mhm.
sixth sense, and
Yeah.
fantastic physician. Just like I said, documentation wasn't great, but that's kind of the
Right.
example of what you're asking for.
Yeah. Wow. Okay. I don't like to hear that.
Yeah, it's sad, really. It's
Mhm.
and that's part of the reason I left the government is because towards the end of my career, we were targeting physicians that were not criminals. They just maybe had not dotted an
Yeah.
I or crossed a T, and it got to the point that I was getting like embarrassed and worried. I didn't want to be a
Yeah.
part of that. If they're
Yeah.
criminals, that's one thing. Let's lock them up. But
Yeah.
if they're just naive physicians or maybe not good at documentation, yes, send them to a CME on controlled substance prescribing,
Right.
or look at them administratively, but don't raid their office with a search warrant in broad daylight and destroy their career because they're a little naive or they
Yeah.
are
Well,
not documenting.
not to put you on the spot, so maybe
Sure.
you can't answer it or prefer not to answer, but do you have any, like, why? I mean, is it just a quota to fill that you have to, I mean, why?
There's a lot of things, there's the opiate epidemic,
Sure.
which they blame a lot on. But if you look, most of those statistics belong to illicit drugs, and they may have been on opiate medication when they overdosed
Sure.
on the illicit drug, and then they contribute that, uh, you know, overdose to the prescription drug, but they kind of overlook the illicit drug. So they want to charge the doctor because he has the medication in their system, but really it was the patient that went out and chose to do heroin, that
Mhm.
night. When they had no heroin in their system, on any urine drug screens or, no criminal record, no nothing. I've seen physicians charged with that. They try to do that with another physician that we exonerated in Kentucky, and he had had about 5 overdoses, none that he was even aware of. They actually just kept digging until they found patients that are overdosed. And even though some of these coroner reports listed the number one reason as cardiac arrest, and so they were using these reports. They had a so-called expert medical examiner come in, coroner, and testify that nope, that's wrong on that autopsy report. It should have been opiates first and then cardiac arrest, or no,
Yeah.
just because he had heroin in the system, that's wrong because the opiates, and the benzos contributed to this, overdose, and you know, uh, actually charged the guy and used those didn't use those deaths as criminal counts, but was able to convince the judge to allow the overdose reports and death records to be used as evidence to show that the doctor was inappropriately prescribing controlled substances on other counts.
Wow.
I mean,
Wow.
it was the craziest thing. But like I said, again, luckily the jury had common sense and saw through it and exonerated him as well.
Hmm. Okay. Well, interesting, fascinating. Thank you very much for your time, Mike.
You're welcome.
Yeah, so pharmacists and physicians out there, you heard it. Do your corresponding responsibility, have your checklist, document it, and because yeah, if it's not documented, it didn't happen.
Exactly.
Right. Yeah. Okay. All right. Thank you, Mike.
Thank you, Terry.